Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. Here we place women's health and feminism front and center where they belong, engaging in conversations that range from the fundamental to the fearless. With insights from expert guests, we aim to break through the barriers of the patriarchy and envision a new world led by the Gynarchy. So let's get started and dive right in. Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel, and today we are talking about fibroids, a very common GYN condition. My guest today is Dr. Cheruba Prabhakar. She is a board-certified OBGYN and fellowship-trained minimally invasive surgeon with expertise in fertility-sparing fibroid surgery and endometrial polyp removal. Dr. Prabakar offers cutting-edge solutions for gynecologic issues, particularly for women navigating IVF and hormonal challenges. Her practice, La Marinda Gynecology and Surgery, reflects her mission to empower women at every stage of life through accessible, sustainable, and holistic care. As a certified menopause practitioner, Dr. Prabhakar is passionate about educating women and debunking myths surrounding hormonal therapy and women's health. She extends her impact globally by supporting educational initiatives for girls in South India. She has been featured in media outlets such as Arise America and Essence Magazine, and is a frequent speaker on webinars at conferences and events. Welcome, Cheruba. How are you?
Yeah, I'm doing great.
Thank you for being on. So I'm excited to talk to you about this. Before I get started on the topic, I'd love to hear a little bit more about my guest's background. If you'd like to share, how you got into, why you decided to do, get into this field, maybe.
Yes. So I actually never wanted to be an OBGYN until I went to medical school. And even when I started my rotations, it was just not something that I ever thought I would love until I did my rotation. And then I just really felt like it was a calling and decided to do it and have never looked back. And then regarding my fellowship, I trained in New York, where I saw a lot of patients with fibroids, heavy bleeding, and decided that I really wanted to take care of these women and specialize in this. So I did a 2-year fellowship and then decided to be known as the fibroid doc, because it's something that I really enjoy taking care of, and something that is a big quality of life issue for many, many women around the world. So that's a little bit about how I got into fibroids. And I'm in the Bay Area in California now, and I run my own practice, La Marinda Gynecology and Surgery, and we take care of women through all stages of life.
Okay, great. Thank you so much for the background. Yeah, I didn't really have a specialty picked out in medical school either, but I did like the idea of surgery, but I had much more fun doing the OBGYN rotations. And then, of course, we have a bit of surgery, So, and you're doing just surgery, right?
Mostly, yes. I don't do obstetrics anymore in my practice. So really, really focused on gynecology and surgery.
Okay. So I wanted to talk about fibroids because, they're surprisingly common, super common. They cause a lot of health issues for women, like pain and bleeding and anemia. And a lot of women are often just struggling in silence. And they don't even know they have these, they're often diagnosed late, sometimes after years of suffering. So, and I think it's just confusing, like, what are they, So, I think a lot of women probably, have a lot of questions about what they are and how to manage them. And I think with a lot of women's health topics, women's research is just underfunded in it and we don't have enough of it, right? So I guess do you want to start simply by maybe explaining what they are?
Yes, let's do that. As you said, there are so many women who just suffer in silence. And part of that, I think, is because many women don't know what normal is. So if they've always been used to having really heavy periods and they're 20s and, late 20s, early 30s, they think that that's really what's normal. And they don't think to get it checked out. Maybe I have something going on. And so that's how fibroids get missed a lot in the second decade of life. And then I end up seeing these patients in their mid 30s or even early 40s, or whenever it is that they're trying to get pregnant. So fibroids are most of the time benign, almost always. There are benign tumors of the uterus. So they're essentially like balls of tissue that grow on top of the uterus. They can grow in the muscle of the uterus or even inside the uterus. And they're there, and if they're small, sometimes they may not cause any symptoms, and so many women may not even know that they have fibroids. Yet 90% of women will be diagnosed with one by the time they are 50. And if you're African American, this actually jumps up to 90%. So it's very, very common.
Oh, I think you said 90 twice.
Oh, sorry, 80%.
Okay. Because I was going to ask you, I'm like, 90%, that's a lot. Okay. So 90, but even 80% is quite a lot.
Yeah.
Surprising.
80%. Yeah. It's a big number. And then if you're dark,
if you're African
American, or even South Asian, actually, those of us with more melanin have a higher chance. It goes up to 90% by the time we're 50. So it's super, super common. And again, they're mostly benign. And whether you want to do something about it or not really depends on your symptoms.
And do you want to go over like some of the symptoms that should maybe make women think of like, what if something's wrong, or, that might suggest a fibroid?
Yes.
Or other problems that you might want to look into. What are the biggest symptoms, I guess, when you have fibroids?
Yes. So definitely heavy bleeding. I would say that's the number one. So maybe you're getting a regular period every 28 or 30 days, but it's just really, really heavy. So maybe it's lasting a week or 10 days, or maybe you're changing a pad or a tampon every hour, which is not normal. And so if that's happening, that's kind of a red flag. Perhaps you feel something in your abdomen. You're like, oh, like I'm definitely not pregnant, but I feel there's like a ball of tissue or some mass over there. Maybe when you roll over in bed or you turn around, you feel like there's this like ball moving with you. That's often a sign that perhaps you could have a fibroid and you need to get that checked out. Sometimes painful sex can be another one. Frequent urination, because fibroids can sit on the bladder and can cause pressure. So these are some of the symptoms. And certainly infertility is another big one. So if you've got fibroids and you're having recurrent miscarriages or you're not able to get pregnant, you definitely want to get checked out for fibroids.
Okay. And like, what kind of tests do you usually do when you're seeing the patient? Like what's the most common way that you diagnose it?
Yeah, the most common way is just a pelvic ultrasound and a physical exam. So a lot of times when I actually do a pelvic exam, I can pick it up. If it's very small, we may not be able to recognize that on an exam, but an ultrasound is often sufficient. And an ultrasound is no radiation. It's not a very painful exam and can be done easily.
Yeah, I was going to say, this is actually a great argument for going in for your checkups, because I've definitely diagnosed fibroids without the ultrasound, like and women are sometimes surprised, and that will sometimes open the conversation of like, do you have pain? Do you have period problems? And then suddenly they realize, yeah, actually I have,
Yeah.
So.
A lot of times they can also be slow growing. So you may just sort of get used to it being in your pelvis. And then when we do the exam, we know that that's not normal. And I've said to patients, oh, I think you have a fibroid. Your belly is all the way up to your uterus is all the way up to your belly button. And they're so shocked because it's just in there over years that they just sort of got used to it.
Right. They can be slow growing. So, and do you want to go over, like you mentioned that it can cause infertility? Do you want to go over how that how it affects your fertility?
Yes. So fibroids can start to protrude or jut into the actual cavity of the uterus. So when we think about the uterus, there's muscle, and then there's the actual space inside where a baby forms. And that's where your lining sheds during your period. So right there, if you've got a fibroid growing, then when an embryo tries to implant, or when the egg and the sperm try to meet and find a spot to implant it, it's not able to. So, or if it does, then it's pushed out pretty fast within a few weeks, causing a miscarriage. So often this is the number one cause in which it can prevent fertility. And then secondly, fibroids also often coexist with another condition called endometriosis, which is a whole different topic. But together, the physical aspect of it, and then the chemical aspect of endometriosis, and the inflammatory little particles that it spreads into the pelvis, can definitely also cause infertility.
How many patients with fibroids typically also have endometriosis? Is that something you know offhand?
Yeah, 40%.
Oh, that's a
Yeah.
large number. I didn't
Yes.
realize that. Okay, so since you're operating quite a bit on these patients, you must see it
Yes.
firsthand.
Yes. I see
Okay.
it quite often, even though a lot of times we don't know that diagnosis ahead of time, but we're going in
Mhm.
for fibroids. But then I do
Mhm.
see endometriosis as well.
Besides ultrasounds, is there any other testing that you do?
The next best test is an MRI, because we can really see the borders of the fibroids and where they intersect with the lining of the uterus. So especially if we are suggesting surgery for a patient, I like to get an MRI so I can see exactly how many there are, what is the relationship to each other, and how does it affect the actual uterine cavity.
One of the things about fibroids that I think people often find really shocking is just how big they can get, you know? And we often describe, like patients have asked me, they're like, why do you describe it? Like either they see the note or the ultrasound, they'll say, it's because they see that we sometimes will describe it in terms of weeks,
Yeah.
which is and it's funny because you forget, like, oh yeah, I have to explain what that means. So do you want to explain that, because it is kind of interesting, I think,
Yes, yes. So fibroid size.
terminology.
Yeah, we often report it in centimeters, but sometimes we describe it in weeks, and it's correlated to the weeks of how long, far along a baby would be. So, for example, just a rule of thumb is if the fibroid is up to your belly button, that equals about a 20-week size baby or a 5-month-old baby. So I know it's always fascinating to put that into
Right.
perspective for patients. Wow, that's really big. Um,
Yes, yes.
so yeah, that's a good point.
Right. Oh, and right. And we'll say like 20-week sized uterus due to the
Yes.
fibroid. Right. So how big is the largest fibroid you've seen?
So I was just thinking about that, and I think the last one, the biggest one I took out was 25 centimeters. So it
Oh.
was definitely big. That one was pretty much up to the patient's chest. It was a very, very large
Wow.
fibroid. Yeah.
Wow. Yeah. And for perspective, like a baby's head is about 10. So that's like 10 centimeters diameter. So it's double or more. Wow. Out of curiosity, what kind of symptom did she know that something was wrong?
Yes. So she definitely looked pregnant. And I think a lot
Mm.
of people would ask her, like, hey, when are you due? And, she's not really pregnant. And so finally she was like, oh, I just have to do something about it. I'm tired of people asking me. And of course, feeling pregnant and kind of walking like she's
Yes.
pregnant,
Yeah.
and it's started to affect her life. So, yeah.
She must have had horrible periods. No? Yeah.
Interestingly, she did not have really bad periods. It was more the bulk symptoms that was just big and heavy.
Wow.
Mhm.
Okay.
The location of the fibroid. It was more on top of her uterus. And so it was more that she was feeling that pressure and that pain rather than the bleeding.
Okay, right, right. Like, so if the fibroid's more dangling off the uterus, it's going to be
Yes.
less likely to interfere. I
Yes.
think that's actually kind of interesting, maybe to describe like what the mechanism is of like this heavier bleeding.
Yeah, yeah. When the fibroid starts to invade the muscle of the uterus, or it starts to get all the way into the cavity of the uterus, then it starts to disrupt the blood supply around there that's feeding the lining of the uterus and the muscle. And so this starts to cause extremely heavy bleeding and sometimes erratic bleeding, maybe between your periods. And so it can start to become unpredictable.
So I thought another thing that would be good to talk about is just, some of the treatment options. So, obviously you can have very small fibroids and then very large ones. And when they're not so enormous, sometimes you can just do medical management, right? So what kind of options does that include?
Yeah. So for the number one symptom, I would say is bleeding. And so for patients who know they have fibroids, they're bleeding heavily, a quick medical option is just a birth control pill. And we have different kinds, we have different doses, we have estrogen and progesterone birth control. We have progesterone only. So there's many options there, but just to prevent them from continuing to bleed heavily and become anemic, this is a quick one that we can do. And then if we are thinking about shrinking fibroids because they're large and patients are finding it uncomfortable, but they don't quite want to do surgery, then we have some injections and some other options to help just bring the size down. And then if patients are trying to get pregnant and they really need this fibroid out of there, or it's just so big that it's starting to show and they're starting to get uncomfortable, or if they've tried a bunch of medications and nothing has really worked or worked very well, then we talk about surgery.
Okay. So so that injectable, you mean like Lupron?
Yes.
Okay.
Yeah. Lupron,
And
traditionally that's what's been used, although I think it's kind of falling out of favor now.
are there other meds that you recommend then?
We do have medications like Myfembree that really help with the bleeding and can also shrink the size of the fibroid. So that's another newer one that I like. Yeah.
And non-hormonal options as well.
Non-hormonal we don't really have any good ones.
Okay.
Yeah.
So, okay, do you want to, are there ever times when you will just watch a fibroid and not do anything? Or
Yeah,
fibroids,
definitely. I mean, we don't have to treat all fibroids, especially if they are completely not causing any symptoms, the patient is fine with it, no bleeding, nothing like that, then yeah, we can just kind of watch it. And I recommend an ultrasound at least every year to make sure it's not growing. Yeah, but you don't have to do something.
Yeah, that was my next question is how often do you scan? Because that's also like something I'll debate with myself, like, well, when should I look again? um,
If it's not a very big fibroid, it's just there. We kind of found it incidentally when doing an ultrasound for something else or imaging for something else. I would just tell the patient once a year. Yeah.
Yeah. And sometimes like if it's really, not very big and we've followed it and we know it's not actively growing, like I'll just recommend an exam once a year. And if I can tell that it's the same every single year, then, then you don't necessarily even need the ultrasound every year, right?
Exactly. Exactly. Yes.
So I did want to get into, talking about surgery and the options. But I thought maybe we'd start with you explaining, you're a minimally invasive gynecologic surgeon, you fellowship trained. So I thought maybe you could start by explaining to people what that means.
Yes. So during OBGYN residency, which is 4 years, we get trained not just in the obstetric part, which is delivering babies, but also gynecology and surgery. So most OBGYNs are comfortable doing basic procedures for even fibroids, ovarian cysts, maybe some laparoscopic procedures, some robotic procedures. But a fellowship is an additional amount of training. So this fellowship is an additional 2 years really focusing on the surgical aspect. So we don't do any obstetrics, we don't do much office gynecology. It's really focusing on surgery, learning the techniques, learning more advanced techniques, and taking care of those patients. So that's what a fellowship is. And I did mine in New York.
Okay. So what does like minimally invasive surgery for fibroids look like? What are the different kinds of surgeries you might do?
Yes. So when we think about surgery in general, traditionally surgery has required a large incision, kind of like a C-section incision for gynecologic surgery. Sometimes you'll see patients with, up and down incisions, kind of from their belly button down, depending why they were getting it done. But that's traditionally what we think of surgery, and we think of patients staying in the hospital for, 3 to 5 days and kind of slowly recovering. Minimally invasive surgery is done with just a few tiny incisions in the belly. So anywhere from 3 to 5 incisions, but they're only about 5 millimeters to 8 millimeters large. So that is like a pencil eraser, almost the width of a pencil eraser. So it's pretty small. And we do the whole surgery that way. So you don't have any big scars. And you can actually leave the same day, almost always, which is nice because you can recover in your own home, in your own space. You can start walking the very next day and getting back to some of your regular activities. So it's a much faster recovery, less blood loss, and you don't need as much pain medication, and you can just recover much faster. So less risk of complications as well.
Okay. Yeah, maybe we should go over that, like the complications that you can have with any type of surgery and maybe how it differs with like, a larger operation.
Yeah, with the larger operation, I'm thinking mainly blood loss is number one. And with a minimally invasive surgery, we just don't lose that much blood. So that's number one. So less risk of blood loss, less risk of blood transfusion. And then we also think about tissue damage. When we open a patient with a big incision, our hands are all over the tissues and we're trying to dissect it out and things like that. And especially for fertility patients, this can cause scar tissue. And so that can kind of become a big deal. And so try not to create so much tissue trauma, but it's hard when you do an open surgery. Of course, your hands have to be in there. Now, with minimally invasive surgery, we use very fine tipped instruments to do the surgery. And so there's less tissue trauma, less kind of manipulating that tissue. And so less risk of scar tissue, which is really nice. So blood loss, I would say, is number one. And number two, just risk of adhesions and scar tissue. And then I would say those are the two like biggest differences.
How often are you seeing like injury to internal organs?
Yeah, very rare. I mean, I would say it's less than 5% for minimally invasive surgery. And by this, we mean risk of injury to the bowel, which is your intestines, bladder, major blood vessels, things like that. And with open surgery or traditional surgery, this risk goes up to about 10%. So 5 to 10% of a risk of injury to these nearby organs. And I think the number one reason is because you can just see better with minimally invasive surgery because you have much more magnification. I often use a robot, the Da Vinci robot. So that actually has 10x magnification than the human eye.
I was going to ask. Okay.
And it's 3D. So you can just see a lot better. So if you're near the ureter or near some nerves or blood vessels, you can just see a lot better versus with an open surgery, sure, you can touch the tissue and all of that, but your visualization, under the uterus or on the side of the uterus can be kind of limited. Yeah.
So, and you're doing hysterectomies and myomectomies. Myomectomies meaning like removing fibroids that way, robotically and minimal, laparoscopically. Yes. Okay. So the other thing it just occurred to me is like, what about uterine artery embolization? I referred to a decent number of patients for that.
Yeah.
How often are you recommending that?
So I always bring it up as an option for patients. And by uterine artery embolization, we're talking about a procedure that's done by a radiologist. And this is where they put a catheter, typically in your groin. Some do it through the radial artery right by your hand here. And they shoot up these.
I did not realize that.
Yeah, there's a group out of Dallas that does that. So okay. Yeah, right by your wrist.
That seems like a long way to travel to get to the uterine arteries. Okay, I'm gonna have to look that up. Interesting.
Yeah, right? Yes. So and they shoot up these little polypropylene beads almost that go and cut off blood supply to the uterine arteries. And so the idea is that it shrinks the fibroids. And the shrinkage is about 50% over the year. That's kind of what they quote. And for patients who are very, very close to menopause, I think this is an excellent option because it's not always permanent. So sometimes fibroids can start to regrow. And those beads kind of get dislodged after a few years. So for a younger patient, I don't think it's the best option. For patients who are trying to get pregnant, it's not the best option because we've just gone and cut off blood supply to different parts of the uterus and we don't know what's going to work and what's not. So yeah.
Yes, I think it's contraindicated, right? Like after uterine or not. I mean, I know patients will get pregnant sometimes, but we don't recommend it after.
Yeah, I think you can get pregnant, but yeah, we don't. That's not the preferred method of.
Right. So, okay. What the other thing we didn't talk about was maybe hysteroscopic or hysteroscopy, if you want to talk about that, what that is, and that method of removing fibroids.
Yes. So that is also a minimally invasive option. If you're somebody who has very small fibroids and if they are actually inside the uterine cavity, I shouldn't always say small because there are some bigger fibroids we also remove through there, even 4 or 5 centimeter fibroids. But traditionally, this is for smaller fibroids, not like 10 or 20 centimeter fibroids. Mm-hmm. And they have to be pushing into the space inside the uterus or the cavity. Because the idea here is that we're able to go through the cervix, through the vagina, cervix, and the uterus from below without any incisions. And so I do this a lot for my fertility patients who are trying to do IVF and they have these small fibroids and we're trying to get at them. So yeah, that's a pretty common procedure that I do.
Yes. That's something I probably do more of than the other things. I refer out to surgeons like you for anything abdominal fibroid related. So so your general GYN can sometimes do those, right? So you mentioned like sometimes fibroids regrowing or, how often does that happen? Like if you're a young person and you decide to remove a fibroid, what are the odds of it coming back? Is that something offhand, like a statistic on that?
Usually quote about a 30% chance of fibroid regrowth. So have we operated on patients again? Yes. But maybe when they regrow, they're smaller or they're in different locations. So they're not really going to impact fertility or bleeding. So yes, I always caution patients that just because we remove fibroids now, that doesn't mean that they're going to be fibroid free forever. They may be, but the chance of them growing back, or obviously not the same fibroids, but different fibroids, is higher because there's something about that patient's genetics that just makes them grow fibroids.
Okay. Yeah. And how often does it run in families? Pretty common.
Pretty common. I mean, a lot of patients will say, my mom had a hysterectomy, my grandmother, my aunt. So it's rare that I see somebody with 0 family history.
So if you, let's say you have a family history of fibroids, is there something patients can do to prevent it? They'll ask, I think it's I'm not aware of anything that you can do to reduce your risk, but I guess, do you have any recommendations?
So the number one thing I talk about is lifestyle, because this has shown to help. So eating a more plant-based diet, exercising, reducing alcohol, moving, good sleep to protect your immune system. All of these things can help fibroids from growing or from more fibroids from forming. My patients will say as soon as I clean up my diet, the bleeding gets better. And so I've definitely also heard that. So that's number one for fibroids. Vitamin D supplementation has also, their studies have shown that helps. So that's one of the vitamins that I recommend for all of my patients.
Okay.
So there's a couple of those things that you can do. But if you have a family history, really being on top of it for yourself in terms of screening, getting that ultrasound, that's going to be key.
You mentioned, sometimes needing to remove fibroids to help with fertility issues, right? So is there a certain amount of time someone should wait after, having a surgery like this before trying to get pregnant?
So for any type of open surgery, abdominal surgery, or robotic, we do recommend 6 months at the least. And then for hysteroscopic fibroid removal, there's really no big waiting time, usually maybe just 6 to 8 weeks.
Okay. And what do you feel are like the biggest issues in fibroid care that you wish were addressed more, maybe?
Oh, I love that question. So I think many women are dismissed. They have heavy bleeding. Maybe people on their team know they have fibroids, and yet they're kind of told to deal with it, or it's just, here's a pill or take some ibuprofen, rather than really sitting down and having a full discussion with them as to all the options. I think that's the most frustrating thing, that patients feel that nobody ever told them that there was something they could do. And now they're in this position where they have 30 fibroids or, these ginormous fibroids. And now what do they do? That's very upsetting.
Right. Because they're benign and they might not be very big looking on an ultrasound. I can see how, their symptoms could be dismissed. So yeah, and I think what you said earlier about periods, like women don't know what is abnormal. And so they accept a lot of, accept a lot of erratic,
Suffering.
heavy bleeding. Yeah, I know.
A lot of pain and suffering.
Sometimes I'll share with patients. I mean, I don't have fibroids, but I, for example, use the Mirena IUD, and I just did not have periods for decades. So I'm like, it's a great life.
Right? Yes.
So even, so I think it's just nice because it really does, periods do really affect us every month and interfere with our lives, right?
Absolutely. I mean, I have so many patients with kids, and, they can't really spend time with them, or they can't plan their next family vacation because they don't know when they're going to have this massive bleed out. Right.
Yes. And I think sometimes people avoid treatment too because they think it's going to be really hard to recover from. Like, what kind of counseling do you do about that, about the recovery time for the types of things that you do for treatment?
I mean, for the hysteroscopic procedures, patients go home the same day within an hour of the procedure, and they're pretty much good to go the next day. So that's a very, very low recovery time. For the robotic procedures, that's about 6 weeks for full recovery, and about 2 weeks to pretty much get back on their feet and do most things, including driving. So that's not a huge recovery, but 6 weeks to go to the gym and lift the heavy weights and do all of those things. And then for the abdominal procedures, if we do have to open somebody, then it's a full recovery is 8 weeks.
Okay. And that's being out of work that period of time.
Yeah. But of course, now many people work from home. So
right.
A lot of people go back, maybe part-time sooner than that. So we have ways to, work around that. But yes, if you are doing like a physical job, then the full recovery for that is 8 weeks. But most patients are able to plan that around vacations, let their boss know ahead of time. And at the end of the day, it's just such an improvement in their quality of life.
Have you so how often do you end up finding something more serious on the pathology report? Like when you've done a surgery, done a hysterectomy or removed fibroids, a myomectomy, and sent this to pathology, like how often are you seeing like a cancer that you didn't expect?
It's rare. I think in the last 10 years, I've seen it twice. And the patients were older. They were in their 60s and they were bleeding. And I was like, this is not normal. And, they ended up doing a hysterectomy, and things looked fine during the hysterectomy. There was nothing that looked abnormal or anything. But then the final pathology came back as cancer. Yeah.
And were these surgery, maybe not, we won't talk about the specifics for these cases, but, I think there were like a couple of news reports of women having fibroids removed laparoscopically and, morcellating and then ending up having cancers that spread. So how, do you have a process for choosing the right patient and, to kind of prevent that, your thoughts on that, I guess?
Yeah. So those reports were using kind of the old school morcellator that we used to use, which was, it kind of looked like a gun, and it would suck up the fibroid, and you press this button and it would twirl around, and it would chew up the fibroid, but it would also scatter pieces of the fibroid around the pelvis as it was doing this. So at the end of the case, you had to go and kind of pick up these little pieces. Now, when we morcellate, we do it with a knife and with our hand. And so we're not spilling pieces of fibroid in place, in different places. We're kind of trying to remove it as one whole piece. And we usually put the fibroid or the uterus in a bag before we even do this. So we have much more safe options now, to do this. So if I do think though that, this fibroid is growing very rapidly, or on the MRI, there's some weird blood vessels that make it look like this could be cancerous, then I do counsel the patient. And then sometimes we do just decide to open so that we can take the whole uterus or the fibroid in one piece, and we're not even chopping it up or anything, because if it is cancer, then the pathologist would like to have the whole specimen in one piece so they can stage it and grade it appropriately.
Right. And lower risk of it, spreading around, right? So let me see. Another thing that you often see hand in hand on these scans with fibroids are like adenomyosis, right?
Yes.
Do you want to share? So patients are often asking me like, what is, I think that a lot of people watching who are interested in fibroids will have that on their report as well. So how often does that occur, and what is that?
Yeah, that's a good question. And I think it's one of the more poorly understood things in gynecology and gynecologic surgery. But adenomyosis is when the uterus starts to become super spongy and starts to soak up a lot of blood. And then when it squeezes down, it just hoses that blood out. So the number one kind of symptom for patients is really, really heavy bleeding and extreme cramping and pain. And it's thought that this is because endometriotic glands from inside the lining of the uterus start to bury themselves in the wall of the uterus, causing this more spongy looking uterus. And I'm seeing it more and more now in reports.
I see it all the time.
I feel like it's getting to be really common. Sometimes I think after childbirth, the architecture of the uterus also changes that can lead to adenomyosis. Again, it's only clinically relevant if the patient is having very heavy bleeding or pain, which usually they do. And so the best treatment for that is a hysterectomy.
Okay. Thank you so much. Do you have other thoughts to share? I mean, I went through kind of the basics of fibroid treatment, but if there's anything else you want to share?
Yes, no, those are really, really good questions. And we covered a lot of information. I think what I would end with is that patients should really advocate for themselves in terms of their symptoms. If you're hearing from someone that, oh, this is just normal, but meanwhile, you're hemorrhaging and your life is not happening the way you want to, and you can't take care of your kids and your family and yourself, then, get a second opinion and make sure that you get to the bottom of it, because there are treatments out there for you.
Yes, thank you so much. So, Cheruba, can you share any future, do you have any projects, anything going on that you want to share with the audience, or, and also maybe where they can find you?
Yes. So you can find me across all social media platforms, including YouTube, at the Fibroid Doc. So that is my handle across TikTok, Instagram, YouTube. And this year, I'm going to host a series of 12 free webinars on fibroids: what causes them, hormonal treatments, surgical treatments, recovery, fertility, all the things you ever wanted to know about fibroids. So I'll be releasing that at the end of the month. You can find that on my website, on my social media. Register for free, share it with friends, and bring your questions.
Thank you. I'm glad I asked that question. I don't know how I knew you had something else going on. So what's your website? So your handle is the Fibroid Doc.
Yes.
And
so my website is lamarindagyn.com. La Marinda is the area that my practice is at. So it's just lamarindagyn.com. And we're in the Bay Area. So if you're anywhere in California and you're somebody who wants a second opinion or just a consult, you can definitely make a virtual visit with me anywhere in California. And of course, if you're in the Bay Area, you can come and see me in person. And if you're anywhere in the world and you just want to talk about fibroids, you've been to a bunch of doctors, you just want to talk about it a little bit more, get another opinion, we can do a fibroid coaching hour where I do that for you, not as a patient-physician relationship, but just more of as a coach. And this is for anyone outside California. So you can reach us and let us know.
Thank you. It was really nice to talk to you. Thank you so much.
Thank you so much for having me. I appreciate it.
Okay, here's my closing thought for today. In the patriarchy, women's symptoms such as pain and bleeding are often minimized, so diagnosis and treatment of conditions such as fibroids are often delayed. This is especially the case for women of color who have a disproportionately higher risk of having fibroids. In the Gynarchy, women's health and well-being are prioritized, and we take women's pain, period problems, and other symptoms seriously. We advocate for more research, early diagnosis, and increasing access to treatments. So down with the patriarchy and up with the Gynarchy. Thank you so much for listening. If you've enjoyed this podcast, please consider leaving us a review on one of the podcast platforms. Thank you. Did you enjoy this episode of the Gynarchy Podcast? Know someone else who might enjoy this conversation? Make sure to subscribe and share the show with your friends and family. Find us on Apple, Spotify, YouTube, and just about anywhere you find podcasts. On social media, we can be found on Blue Sky, Instagram, and TikTok at The Gynarchy. Thank you so much for listening.